Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new TEAM-CBT. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello, Rhonda.
Hello, David, and hello to our guest, Jeff Lazarus.
Hello. Very happy, very excited, very honored to be here.
Well, we're really happy that you're joining us. Is it okay if I call you Jeff?
Please.
Jeff is going to be talking about the use of team therapy with children and adolescents. And before I introduce him, we got this really incredible endorsement regarding podcast episode 309, which featured Mark Noble on the topic of loneliness, and Jason Mino, who people might remember from podcast 303. He was featured on that episode. And Jason emailed us, I loved this podcast. I've been struggling with loneliness a lot in the past. And for almost my whole life, I've been plagued by vivid dreams about having the greatest love of my life caress me, kiss me, and make me feel better than anything else in the world. But then I'd wake up from the dream and I'd start sobbing and feeling so alone and miserable for days. Many days I'd actually feel intense anxiety about going to sleep, fearing that I'd have another one of those dreams. I started becoming more anxious about it and started having the dreams even more. Then one day after reading Feeling Great, I decided to try to tackle this anxiety and misery using cognitive flooding. I imagined the worst possible thing that could happen and tried to make myself feel as anxious as possible. For me, that was imagining myself going to sleep every single night for the rest of my life, and I would have the most realistic and intense dreams about the most perfect lover who I would never meet in real life, and I'd experience the greatest love my brain could create, and then I'd wake up alone. I suddenly burst into laughter. That actually sounded fantastic to me. I could do whatever I wanted during the day, and then while I slept, I'd have the greatest love a brain can feel all night long. I'd really look forward to sleeping. My anxiety vanished, and ironically, I haven't had one of those dreams since. Oh well, I guess I'll go learn how to lucid dream again.
Cool. What a great note. Jason is really awesome. Thank you, Jason, for that really neat note.
Yeah, that was cool. Okay, so let me read about Jeff Lazarus. So Jeff Lazarus, who I think of as a dear friend, is a California pediatrician who completed his residency in pediatrics at Stanford University Medical Center. Jeff practiced general pediatrics for 27 years and then subspecialized for the past 22 years in the use of medical hypnosis for children, adolescents, and adults experiencing various common health conditions. Jeff has lectured extensively both nationally and internationally. He's an expert in the practical use of medical hypnosis for the treatment of performance anxiety, headaches, nighttime bedding, gastrointestinal conditions, and tics, both with and without Tourette syndrome. Jeff has published articles and chapters on these topics. He is one of only 8 pediatricians in the United States who is an approved consultant with the American Society for Clinical Hypnosis, and he's been a faculty member of the U.S. National Pediatric Hypnosis Training Institute since 2014. Jeff developed 2 home video programs, and one is for nighttime bedwetting, and the other is for patients with GI gastrointestinal disorders. And he's here because he's trained extensively with David Burns and lectured internationally and nationally about how to apply the TEAM model to children and adolescents. So, yay, Jeff.
Well, thank you so much, Rhonda, for that nice intro. And David and Rhonda, thank you for this opportunity. I'm just so so grateful to you, David, for so much that you've done for me, things that you know and things that you don't know, how you've helped me both personally and professionally through the Tuesday group, through hikes, through, I could take the whole hour just talking about that, but I'm just so eternally grateful. So thank you.
So Jeff, you were in David's Tuesday group, yes?
It was phenomenal, yeah.
Do you remember when you first began?
Yeah, I knew nothing. I was green. I knew nothing about CBT, and what an opportunity. And the 5 secrets. I mean, all these wonderful memories come back to me. The 5 secrets are absolutely life-changing. I remember my first experience with the 5 secrets. I'm not proud of this, but there were times that I would get upset with my daughters and probably yell at them. And after learning the 5 secrets, we had a discussion, and I used the 5 secrets. And afterwards, they looked at me shocked, and they said, "Who are you, and where's our dad?"
Yeah.
It was the biggest compliment I could have received. But it's just, I use the 5 secrets just all the time, and it's automatic now, but and even when I get a referral from so I see children, adolescents, and adults, but the majority of my practice is children and adolescents. And when I get a referral from a family, I'll talk to the parent alone first. And, and they send an email, and I provide empathy. Oh my gosh, I can't believe you. I imagine, I'm so sorry that you're going through this, that your child is struggling like this. I imagine you're feeling frustrated and disappointed and worried and sad and maybe even a bit discouraged. And I do that in writing and also when I speak with them. And, I'm just so sad to hear that. I mean, people start crying, but I'm sad. You're the first doctor who's ever talked with us like this. I mean, it just makes me so sad that these are skills that we should all have. But so thanks to you, David. Thank you.
So Jeff, how do you use the team model and the team approach with children and adolescents, especially within your specialty of medical hypnosis?
Well, I find I use every aspect of it. Of course, the testing, and what I'd like to do is share a little bit about how I do it. Thank you for asking. So always testing, of course, and I will share yet another embarrassing story about testing. Gosh, I'm going to tell you all my failures, which is, I think, wonderful. But this was it actually turned out being nice, with a nice ending. I was referred a 17-year-old for bedwetting, and we met the first time. And afterwards, in his evaluation, I didn't do great on the evaluation, the empathy part. And then at the end, what did you like least about the session? He said, the narcissism. I assume he meant me, not him, when he was referring to that, obviously. And I was so embarrassed, and I just felt awful about it. And then he didn't come back for 6 weeks. And then I remembered, I was so grateful that he came back. I said, I read what you said, and I felt so embarrassed. I imagine you felt frustrated and disappointed and surprised and maybe a little annoyed. And I thought that the narcissism tapes that I used to run in all the time were done in the past, but apparently they weren't. And I feel embarrassed. On the other hand, I feel really hopeful. I really liked you. I think you're smart. I think you're fun. I think we can do great work together. And we went on and did some great work together. And then, but what was so meaningful to me at the end of that second visit was, I got high empathy ratings. And what'd you like best about the visit? The sincerity. So here, but had I never done that, without learning the 5 secrets, that opportunity would have never presented itself. So there's just countless things. The testing helps me also. And I'm a pediatrician. I'm not a mental health professional. So it saved me many times. I've had a couple kids who are suicidal. One that I had to, do a quick, admission, or at least sent to the hospital emergency room for something like that I would not have picked up doing David's suicide assessment form. So it also has literally helped patients' lives when I'm able to recognize that and recognize if I'm not the right fit for someone. So So testing and empathy, to me, the empathy is the number one thing. And if you don't connect with someone, at an emotional level, I can be the best hypnotherapist or CBT person in the world, but if you don't connect with someone, it's not going to work. And so empathy is number one, and paradoxical agenda setting is number two. And you can't even get to paradoxical agenda setting without the empathy. So the empathy is really, really key as far as I'm concerned. Yeah.
What did you do to connect with your patients that came to you for hypnosis before you learned TEAM? How did you connect with them before learning TEAM?
Oh, we're taught in our hypnosis training, it was more about, how do you get to know someone? Tell me about your sports and hobbies, and develop rapport and develop positive expectations, which was okay. And I did general pediatrics for a long time, and I knew how to connect with kids and with parents. But this gives me such a deeper, stronger connection. I mean, I look back, I thought, when the things I used to do in the office, I thought were okay, but this just takes it to the next level. It's just to build deeper, stronger relationships. It's just more quickly too, and especially starting off with the testing. And one of the things, David, I was thinking a lot about the conceptualization, and I think this is one of the things. Obviously, David, you talk about mood disorder and habit and addiction and relationship issues and the normal problems that people have, such as, grief, mourning, and grief after a death of a loved one. But to me, there's also conceptualization for all the things, I add the last one, another one, a fifth one, if you will, somatic or body or medical issues. Because as Rhonda said, I see people with headaches, with chronic pain, with irritable bowel syndrome and inflammatory bowel disease, such as Crohn's disease and ulcerative colitis, people with bedwetting, and people with Tics and Tourette syndrome. And what's key to me is that you have to follow the same model for this to work. And so, for example, David, when we talk about, and Rhonda, when we talk about paradoxical agenda setting, it's the same type of thing. When someone has irritable bowel syndrome or something, you set it up, so, what are the, the miracle cure? I get rid of the tummy aches or whatever it is. And then left side of the page, okay, and if there were a magic button on the desk and you could press the button, and with no work on your part at all, the tummy aches go away, would you press the button? Who's going to say no to that? So they press the button. I say, well, I can think of reasons not to press the button. And many of the reasons are similar to anxiety. If someone has stomach aches, well, I get extra attention. I don't have to go to school. I get to avoid certain chores. I get to avoid certain activities. So given all those good reasons, why on earth would you want to press the button? I get to spend more time at home. I can eat what I want. I can watch television all day. I can do video games. So why would you want to press the button? Well, right side, well, it hurts. I miss school. I miss soccer. I'm falling behind in school. So these are things that, with all the physical problems that I see, that the paradoxical agenda setting, just, to me, that saves everything. I am happy to tell a couple stories about this.
Yeah, I was waiting to see if David had a question for you. But yeah, that would be fun to tell us some stories.
So I had an 11-year-old with functional abdominal pain. Functional abdominal pain, for the listeners, means that all the test results are pretty much normal, but the symptoms are real. So someone can have, and the most common example, a simple example, typical example, is a kid who has tummy aches Monday through Friday morning, and then Saturday and doesn't want to go to school, and then Saturday or Sunday the tummy aches are gone, and then Monday morning the tummy aches start up again. But obviously the kid has what we refer to as school avoidance, and there could be reasons. Different reasons can include, maybe there's a mean teacher, maybe there's a bully, maybe the kid has a learning problem, maybe a combination. But for whatever reason, the kid doesn't want to go, and so. And also, when people have this functional abdominal pain, everybody with this problem has anxiety, and increased worrying leads to increased pain, and increased pain leads to increased worrying. Is it going to get better? Is it going to get worse? Will I ever be able to go to school? What if I get pain or with irritable bowel syndrome? What if I have diarrhea during the exam? Or what if I have a stomach ache during soccer practice or during a game? So I always, increased worrying leads to increased symptom leads to increased worrying. And so do you want to work on first, John or Jane? If it's a symptom, then we do some hypnosis is great to take care of symptoms. Wonderful. And if it's the worrying, then typically at the first visit, I'll teach them the magic dial, David's magic dial. And then at subsequent visits, we'll go into the daily mood log. So this little girl wanted to work on her tummy aches first, and she did great. And then after a couple of visits, she wanted to work on anxiety. So, and I remember So she had done so well, and the mother was there, and she said, now that you're doing so well with Dr. Lazarus with the anxiety, what do you think about working on, having sleepovers? And I have a video of this that when I lecture, I show it. You could see her face, the little girl's face. She was not what I would call wildly enthusiastic about this idea about having sleepovers, sleeping at a friend's house. And so I knew better, but I thought, oh, gee, Jeff, I told myself, this is what his mother wants, you can do this. So I took out the same Paradoxical Agenda Setting page, reasons, what would you want to do? You have sleepovers, reasons not to have sleepovers, and I'm more comfortable at home. Reasons not to have sleep, I'm more comfortable at home. I'll be happier at home. I don't have to worry. Then given those good reasons, why would you want to have a sleepover? Well, I get to eat ice cream and kids won't think I'm weird and what have you. And it turned out the reasons not to have sleepovers won. And I did what I thought was a fantastic hypnosis session, and it went over like a lead balloon. It didn't work at all. And had I only listened to that other part of me, I let my ego sadly get the best of me. And so, it's a lesson that you learn. You hope you don't do it again. And I, but that was a wonderful lesson for me. So it's learning.
Now, what was the lesson? Let's spell it out for those of us who are slow learners.
Sure. For this to work, you need the patient has to be motivated. I went on thank you, David, for asking that. I went on what the mother wanted, and it wasn't what the patient wanted. So by doing that, I was wrong. If the patient says, gee, doctor, I really want to be able to get over my anxiety, and I want to be able to sleep at a friend's house and have friends sleep at my house too, but instead I mistakenly did what the mother wanted instead of what the child had wanted. And I didn't empathize with in retrospect, I didn't do a 5 secrets with her. I just moved ahead. And that was, and in retrospect, it was disrespectful to the child, and it was wrong,
And the child was saying, I want to be able to have sleepovers, or only the mother?
No, the mother wanted her to have sleepovers, but when we looked at the paradoxical agenda setting, the left side and the right side, the reasons not to have sleepovers won. But I still went ahead and did a hypnosis session so that she could have sleepovers, but she wasn't motivated. So if you're not motivated, motivated, it's just not going to work. And I should have sat with open hands, meaning, I should have said something, gee, I get it. Sounds like the aroused interested, but you're not quite ready, and that's fine. And one day, if you change your mind, I'd love to help you with it. But I have way too much respect for you than to force you to do something that you don't want to do. And if you change your mind, you just let mom and dad know, and they'll call me. We'll make another appointment, because I think, I could teach you some powerful skills so that you could enjoy sleepovers. And that's a do-over I wish I had.
Jeff, how did you move from being a general pediatrician into doing medical hypnosis with children and teens and adults?
I had plantar warts on the bottom of my foot. And I had seen a friend of mine, a dermatologist in Cleveland, and he did the standard treatment. He froze them, put topical medications on them. And after meeting with him every 3 or 4 weeks for 15 months, there was no change, and I was frustrated. And I remembered many years previously, I'd had a little 5-year-old boy in my practice who had hundreds of warts on the backs of his hands. They were terribly disfiguring. He had been to several dermatologists, even went to a surgeon who wanted to put him under general anesthesia, which fortunately they did not do. And then he went for self-hypnosis one time, and a month later they were gone. Whether you call it self-hypnosis, visualization, guided imagery, mental imagery, daydreaming with a focus, it's all the same thing. And so the mother was telling me the story, and I knew her well. It was her 3rd child. And I remember being with her in the exam room as if it were yesterday. And I asked her, are you telling me the truth, or are you pulling my leg? She said, I'm telling the truth. I said, okay. So I called Rainbow Babies and Children's Hospital, and I was referred to a professor of pediatrics named Karen Olness. Didn't know Dr. Olness at all. Turned out she had co-written the first book on pediatric hypnosis, and she was very generous and agreed to meet with me as a patient. We met one time. She taught me a method commonly used in adults that involves deep muscle group relaxation, muscle group by muscle group. And she said, when your body's relaxed, you can go to a place in your mind where you feel happy, safe, and comfortable. And when you're in that special state of mind, Jeff, tell yourself, I will no longer feed the warts. Do this exercise 10 minutes twice a day and call me in a month. So every time I did it, I visualized the blood vessels constricting at the sites of the warts, and I actually felt tingling only where the warts were. It was really strange. And long story short, 3 weeks later, they were gone, and I was hooked. So I'm so fortunate. I've received training from the top pediatric hypnosis people in the world, from the top adult hypnosis people in the world, and learning CBT from David. I mean, what a privilege and opportunity to learn this at my age. I'm just eternally grateful. So, thank you.
One of the things that we've seen, as you know, in TEAM is the importance of resistance and motivation, and the power of melting away resistance before using techniques, as you know, is pretty fantastic, and is exceeded only by my bewilderment at how slow it appears that an awful lot of mental health professionals are at catching on, and and family members too, keep trying to throw help at people without taking into account what that person really wants. And I think or doesn't want. And I think what you're saying is that even with hypnosis, what people think is some kind of a powerful thing like anesthesia that you can't resist and it'll make your problems disappear, whether it's insomnia or irritable bowel or whatever, that even there are powerful motivational forces at play. And if you don't take them into account, your success rate is going to be a little bit or considerably lower than it would be otherwise, which is really a neat idea. Now, in addition, one thing that we haven't focused on so much in the Tuesday group is the difference between positive and negative motivations. And the classical TEAM thing is you're very self-critical, I'm a bad dad, beating up on yourself, and then you reveal to the patient that this is really, their depression is really an expression of their core values and some really beautiful things about them, and you list all these things and then paradoxically say, my goodness, why would you want to give up all those great, wonderful things that are really your symptoms are really showing about you? And then, of course, the person kind of panics and says, oh, yeah, but I really do want to get rid of them. And then we come in with, as you know, the magic dial. But you're also dealing with what I would consider negative emotions, which is kind of obvious. There's nothing new about it, but the child is having irritable bowel on Monday through Friday, or stomach pain, or whatever it is, complaint that magically disappears on weekends, and it's not that hard to say that the child is trying to avoid going to school. So that's kind of a negative motive. They're trying to avoid something that they're afraid of, and certainly makes a lot of sense. But have you thought about at the integration of these two types of emotion, two types of motivation? The beautiful side of you, which is producing your symptoms, and the side of you that's perhaps a little bit more on the devious side.
Sure, and that's the whole point. Great question, and that's the whole point of the Paradoxical Agenda Setting tool. Like you said, there's actually, the left side of the page is, I think, to look at it, reasons to press the button versus the right side of the page, so that, right now they're caught in a negative loop. And as you say, David, you bring these are unconscious thoughts that they have. I get to stay home. I don't have to do term papers, whatever it is, given those good reasons. Why would you want to change? Those are all the unconscious reasons that people don't think about. And then you bring these reasons to consciousness, and then they can talk back to it. But it's like you said, so it's always the carrot versus a stick. We're always about being positive. Even when I see kids with bedwetting, for example, I'll see someone who's never been dry. I'll meet with him once, and then comes back a week later, he's dry twice. I can say, hey, I see you wet the bed 5 times last week. Why was that? Or I can say, wow, you were dry twice last week. That's fantastic. How did you do that? Even a 5-year-old knows that we want to keep a record of dry nights only, not the negative. I'm not sure I answered your question, David.
I'm not sure either, but it's not terribly important because what you're saying makes really good sense. That there's things we want and things that we're afraid of, and sometimes we might subconsciously manufacture symptoms in the somatic category in order to avoid something we're afraid of, or to get something that we want. I also believe that dark motives play a much bigger role in relationship problems and habits and addictions than in depression and anxiety. Occasionally they're important. Say somebody with borderline personality disorder and severe depression would conceivably have some what you might consider negative motives, as well as very, very positive motives that are dominating the behavior. But for the most part, we can work with someone who's depressed and just show what's great about them, and that's why they're depressed, because of the really beautiful sides of them. But I think that the darker side of human motivation perhaps plays a greater role in somatic complaints. I don't know if you view it like that or not.
I never thought of it like that, but it sure makes sense. And I'm going to have to think about some other things.
It's similar also to the hidden emotion model that you're familiar with, where you're developing some form of anxiety that's actually a symbolic representation of how you're feeling subconsciously, but you don't want to admit. Like you have a new baby and you have fantasies that you claim you can't control, of throwing your baby out the window. And this terrifies you. But what you haven't come to terms with is maybe you're angry about having a new baby and feel overwhelmed with all the responsibilities that you have. And you're too nice to bring that to conscious awareness. So it comes out indirectly through your anxious symptoms. And I think you're saying that it's kind of like the hidden emotion model in a way that you're working with.
Absolutely. In fact, let me tell you a couple stories about hidden emotion that I would have never figured out without your help. So I saw a 10-year-old boy with bedwetting, and I always meet with the parents first, and then I meet with the kid. And then so I met with him 3 times, and he was still not dry, which was very unusual. Typically, there's pretty quick improvement. And he came in for, I don't know, 3rd or 4th visit, I guess. And I said, "What's going on? You're not dry. What's happening?" He says, "Well, I'm afraid that if I'm dry, then I'm going to have to sleep at my cousin's house. And my cousin has a really creepy dog. And if I'm dry, I'm afraid that I'll have to sleep there." So I said, "Wait, how about it? How about if we call mom and we'll discuss it?" Went, got mom in. She came in. I said, "He's afraid that if he sleeps at his cousin's house, he's going to have to, there's a creepy dog. If he's dry, he's afraid to have to sleep there." Mother, "Does he have to sleep there?" Mother said, "Nope, you don't have to sleep at your cousin's house." That night he became dry. So talk about a hidden emotion, David and Rhonda, that we would never figured out otherwise.
The mom said you're going to have to sleep at his house, or you're not going to have. You won't have to.
You won't have to. But he was worried if he was dry, then he'd have to sleep at his house.
Right.
How would I would have never figured that out.
Mm-hmm. Yeah.
Right? In the old days, I would have said, "Oh, he just doesn't want to be dry. He doesn't want to sleep. He sleep at his, have sleepovers." So that was, what a gift from you to be able to do that. I saw a tennis player who developed a fear of flying, another hidden emotion story. And she was referred to me 2 weeks before a major tennis tournament. And her story was that she was a nationally ranked player, and her story was Monday through Thursday, she'd go to school 8 to 3, get picked up, private tennis lesson 3:30 to 6:30, go home, shower, dinner, study. Friday after school, fly or drive to the tennis tournament of the weekend, get there Friday night, Saturday tennis matches, homework in between, Sunday tennis matches in the morning, Sunday afternoon, fly or drive home. And this was her whole life for every week, freshman year, sophomore year, junior year. So I saw her, she was referred to me summer after her junior year. And so here's a kid who's been on more airplanes than we have, flying all those years. Why would she suddenly develop a fear of flying? And I asked her, I explained the hidden emotion. And she said, "Of course, I don't know." I said, "Well, is it fear of success? If you win this tournament, then you're expected to win the next one?" She said, "No." I said, "Fear of failure. If you lose this one, then You've let down your parents and the coach and the team. She said, no. I said, okay. So she went home and she came back the next visit. Big smile. I figured out. I said, what? She said, I'm tennised out. My whole life is tennis and school, tennis and school, tennis and school. She said, I'm going to be a senior. And next year, all my friends and I were going to go away to college somewhere. I want to be home and be a regular kid. I want to, maybe have a boyfriend, go on a date. So I said, great. I said, what do you want to do? She said, I want to give up the national tennis stuff and just play for my high school. I said, great. All you have to do is tell your parents and your coach and you'll be cured. Oh, I can't do that, Dr. Lazarus. I said, of course you can. Why not? She said, they'll be upset. I said, trust me, it'll work out. So she told her coach first, and he was great. He said, it's been a joy coaching you. And if you change your mind one day, I'm going to be here and tennis isn't going anywhere. She told her parents, and to their credit, they said, we've been pushing you. We've been living vicariously through your successes. What would you like to do? And she told them and worked out great. And then she was able to fly to the tournament. But again, David, without learning that from you, I would have never figured those things out.
Yeah, somebody has to teach us. So what would be your take-home message for children and adolescents who have somatic complaints and for their parents?
Great question. The first thing is the complaints are real. Even these kids with function and adolescents with functional abdominal pain and irritable bowel syndrome. And irritable bowel syndrome can consist of pain, nausea, vomiting, diarrhea, constipation, any combination thereof. And you have to just, the first thing is to empathize with them that yes, the pain is real. The kids are not faking it. They're not going to bed at night thinking, oh, I'm going to fake a tummy ache tomorrow so I don't have to go to school or so I don't have to take the math test. So first we have to side with them and say, yeah, the tummy's real. I get it. And imagine and empathize. I imagine you feel frustrated and disappointed and all that stuff that we do, with empathy. And then,
you're talking about acknowledging their feelings in your, yes, it's real. And here are the feelings I imagine you're having.
Yeah. And sometimes, sometimes the kids feel, my parents think I'm faking it. And I don't see that too often, but occasionally, or my sibling will say, oh, you should be able to go to school. But you really have to side with the patient and look at it through their eyes. This is real. And then I imagine you feel frustrated, disappointed, worried, discouraged. And I feel sad to hear about it. On the other hand, I feel hopeful because I'm going to outline an approach that's helped countless children and adolescents around the world with these issues. And incidentally, for the gastrointestinal issues that I mentioned, CBT and hypnosis have been shown to be the most powerful treatments for these issues. So, using both is just amazing. Even CBT without using hypnosis has been shown to help patients with irritable bowel syndrome and such. So, yeah. And I wanted to also mention, you talk about outcome resistance. One of the things, this applies to parents too.
And let me just say that outcome resistance is describing all the reasons that a patient may not want the outcome that they say they want.
Right, good. Outcome and process resistance can apply to the parents too. Parents want to help their kids. It's like David, I'm reminded all the time you say we as therapists want to help our patients. Parents feel the same way about their kid. What parent, loving parent doesn't want their child to get better? But I always do what I affectionately refer to as a parentectomy. And I say that affectionately and with a smile on my face and respectfully to those parents in the audience. Because the studies have shown that the more parents get involved with the problem, the worse it works. So if for example, a kid with bedwetting or irritable bowel syndrome, any of these issues, if the parent pushes it, you got to go to school, push. The harder we push, the harder people push back. So I'm asking the parents to do something that they haven't done the past 10 or 15 years and stay out of the process. The studies show the more parents get involved, the worse it works. I think there are a few reasons for this. One, so when I assign homework, I tell and I meet with the parents and the child that your parents are going to stay out of the process. They're not going to remind you to do the homework. They're not going to remind you to keep the calendar. And the reason I think this is important is otherwise it gives a message, you can't do this without our help. It's one more thing for the parents to nag about with the kid and, empty the garbage, clean your room, do the homework Dr. Lazarus assigned. And again, the harder we push, the harder people push back. But parents do it out of love. They want their kids to succeed. So, they'll remind, are you doing the homework Dr. Lazarus assigned? And it accomplishes just the opposite. And when I talk to the child, privately afterwards, the parent, you empathize with the child. I imagine you feel frustrated and the parents are supposed to stay out of the process and they don't. And the child feels frustrated and irritated and annoyed with the parents. So, it really, David, all these lessons that I've learned from you, I'm just so grateful because it just helps my patients so much.
Right. So the first thing would be to use feeling empathy and support for your child, and be a good listener and let them voice their concerns and complaints without trying to help and without trying to push them to solve the so-called problem. Would a second step be learning to listen to the music behind the complaint? In other words, to understand rather than trying to like the same. Remember the video game guy we had? Do you remember, Rhonda? It was
Yes.
The same thing. Mm-hmm. To understand what's driving the behavior, and try to understand from the very simple and excellent examples that you've given, like the tennis player who gets a fear of flying, and well, why is this happening? What is the subconscious emotion? What is the hidden emotion that this child is having trouble expressing? And it might be something kind of simple and obvious in a way, that maybe they want something that they're too nice to verbalize. Like, maybe I want to have a date. Maybe I want to be wild. Maybe I want to be a kid and don't want to be a tennis star and achieve things with my entire life. Maybe there's other things that would be important to me, or someone who's missing school. It's hard for people, I think, for whatever reasons, to hear these messages. A lot of people, therapists include, have a kind of, I would say, irritating addiction to throwing help at people, whether the people like it or not. And as you point out, that just makes, most of the time, if not always, just makes these kinds of problems a lot worse. It sounds like you're saying that lots of therapists, but parents especially, seem to have a kind of blind spot and don't really listen, aren't really connecting with their children in a loving way. They don't realize this. They think they're helping the kid and pushing the kid in the direction of wonderful things that will help that child in life or later in life. But what they don't see is the child is kind of being treated as an object rather than as a human being with a soul, with feelings, with understood, with feelings that they understand, and some feelings that they're probably kind of hiding from themselves and others. I don't know if this is correct or not.
Absolutely, 100%, David. And it's interesting you mentioned about the tennis player. She, as you taught us, these people with, she probably is conflict avoidant. She's afraid of offending her coach. She's afraid of offending her parents. So, and it's not like she stayed up and I thinking, I know, I'll fake that I'm afraid to fly. That way I don't have to compete in this tournament. This is all unconscious. This is how her mind and body, there's a strong mind-body connection. And this is how her mind and body were able to deal with it by, hey, I'm afraid to fly. And she truly was, so this was how unconsciously her mind and body responded. Yeah.
Yes, I kind of got my start in this from Alan Barber when I was a medical student, and he was working kind of in your area with people who came to Stanford with aches and pains and thick charts and dizziness and somatic complaints that had no organic basis. And the medical system had been wasting hundreds of thousands of dollars on just about all of them with worthless and needless medical tests, searching for some organic cause that didn't exist. And he reported that about half of the time when he would direct the patients, and I found this myself and working in his clinic, patients with chronic pain or headaches or dizziness or chronic fatigue syndrome or some such thing, direct them to identify and solve the problem in their life, which might be an unhappy marriage, or the kids went away to college and the woman has kind of empty nest syndrome, or whatever the issue was that they were not dealing with, and they started dealing with that. Suddenly the problems disappeared. And that was my first exposure to what I later called the hidden emotion model.
Yeah. Still,
the curiosity in my mind, and you may have thought about this and may know the answer, or maybe not, probably not. But I'll ask it anyway, is why might it be that some people, when they have this hidden emotion phenomenon, they're conflict phobic and anger phobic, and they're trying to please everyone, why do some people convert those unconscious feelings into physical complaints like, pain, irritable bowel, and then others convert them into emotional anxiety complaints like fear of flying or panic attacks or obsessive compulsive disorder or chronic worrying or phobias. Any form of anxiety has a high likelihood that the hidden emotion phenomenon is lurking behind it. But they seem to be two distinct routes or outlets for this hidden energy. We had it, by the way, in Tuesday. I know you're not in the Tuesday group anymore, but we had a very prominent case of hidden emotion. In this case, it wasn't all that hidden. A young woman, we're going to do a podcast on it, who was having panic attacks when her parents came to visit from Israel after her being annoyed that she had to visit them in Israel for 20 years. And kind of having a lot of anger and unexpressed negative feelings that she was just carefully avoiding, trying to be nice all the time to mother, but having panic attacks. And but why does it sometimes go into like panic attacks or worrying or phobias or of various kinds, whereas others, it becomes a somatic symptom, a tic or whatever.
Yeah. Well, you're right, David. I don't know. I mean, I would, have to guess that it's just the way people are wired. Some people are wired to have it come out emotionally, as you said, with panic, and some people, there's a strong mind-body connection. When we're upset physically, when we're upset emotionally, it upsets us physically. When we're upset physically, it upsets us emotionally. So there's that strong mind-body connection. But why one person goes into the affective part of the mood change versus someone else with a somatic change, I have no idea.
And even when it goes into anxiety, it's still often somatic, like people with panic attacks are having hyperventilation and rapid heart and sweating and physical pains, but it's still experienced as panic, some fear, or some terrible thing is going to happen. And then where do you see health anxiety on this spectrum? That's there are people kind of in between. They keep going to doctors thinking they have some horrible illness that they don't have.
Yeah, that's a great question. I think a lot of times, and we see this with parents too, sadly. Someone is diagnosed with functional abdominal pain, for example, and they go to their primary care clinician, and then maybe they'll go see the gastroenterologist, and the gastroenterologist will say, "Oh, good news! It's not physical. We know it's irritable bowel syndrome, or it's functional, meaning there's nothing physically wrong, and the treatment for this is behavioral. It's CBT and it's hypnosis." But a lot of parents then they feel, what do you mean? There's nothing wrong with my child. And then they feel guilty. And so they want to go find a diagnosis. They want to find a medical diagnosis for it. So they'll go see another gastroenterologist, not often, but sometimes. And so I think parents are looking for a medical reason. Otherwise, they feel guilty. They feel like there's something wrong with the way they've raised their child, when in fact there isn't. Parents didn't cause this. But I think that's along those same lines.
I have one last question. It's a goofy one, even goofier than my other one. Well, my other one wasn't goofy. It's just that none of us seem to know the answer. But this one would be, a little bit Well, this isn't goofy either. Do you ever see these Munchausen by proxy situations? We actually had one, I believe, in our extended family system, but where you have a mother and child, and the mother has a subconscious need for that child to have illnesses, and they kind of get into a collusive system that can be very destructive and pretty horrible.
Those are terribly sad cases, and I that's beyond my skill set to treat. So but those are very, very sad cases. Yeah, very sad. I wanted to share one fun story, if I may, about a little boy, just to show you that you're never too young for paradoxical agenda setting. I saw a 5-year-old boy who was referred to me because he wouldn't wear his CPAP mask. He had sleep apnea. So he came to me, and they're also cute at this age. And I said, "What brings you here today?" And he looked at me, he said, "You're going to make me wear my CPAP mask." And I had met with the parents. I had prepared them what was going to happen. I said, "No." I said, "What do you mean?" He said, "I've met with 10 doctors. They all want me to wear the mask." I said, "I don't care if you wear your mask. If you want to wear it, fine. If you don't want to wear it, that's fine. That's up to you." And he looked at me absolutely shocked. So I said, "In fact, let's list reasons not to wear your mask." Now, he's 5. He doesn't know how to read or write, but I took out a piece of paper and I start writing, what are some reasons not to wear the mask? What don't you like about it? It doesn't feel good. It feels weird. It smells funny. I'll have to go to school all day. I like having sleep apnea because I get to leave school early. He's in kindergarten. I get to come home early and spend time with my mom and take a nap. So I said, so given those good reasons, why would you want to wear the mask? And he had no reasons to do it. And then he had brought the mask and he ran around the office like a fighter jet pilot. So he was able to wear it for a little bit. Then he came back a few days later and he said, "I want to wear the mask." I said, "Wait a minute, I'm confused." I said, "Last time you were here, you said you didn't want to wear the mask. Let me look at my notes." And I said, "It smells funny. It tastes funny, all that. Why on earth would you want to wear the mask?" He says, "Well, I won't have sleep apnea anymore. I don't like taking naps. I'll be a normal boy without sleep apnea. I won't be tired during the day. I want to have play dates after school. I'll be able to play soccer." And he wanted to be in the school play. That was the biggest thing. He says, "I'll be able to take a theater class and have play dates and, be in the school play." So now that was, so then he was ready. But if I had pushed, I just would have been the 11th doctor to say, "You got to wear your mask," and it wouldn't have worked. Once, he came around, again, paradoxical agenda setting, we just gave him the time and space he needed. And then he was very quickly able to wear the mask. So whether you're 5 years old or 95 years old, this stuff is just magic, David, if we listen to our patients.
Okay, so let me see if I get what you're saying. Here we have this little boy we all know he should be wearing his mask. And he doesn't want to wear his mask. And the parents and all the doctors are trying to get him to wear his mask. And the harder they try, the faster they fail.
Yeah.
Then they comes to see you and you weirdly start telling them, "Well, there's a lot of good reasons not to wear that mask. Why don't we list them all?"
Yeah.
And you're saying that you don't care if he wears the mask or not. So you're doing the exact opposite. And then next time he comes back, he suddenly wants to wear the mask. Maybe I missed some steps in there, but is that what you're telling us? And
that's exactly.
And again, spell that out for those of us who are kind of at the 4th grade level and have to have these things spelled out.
Sure. Yeah, that's exactly what happened, because the harder we push, the harder people push back. He had his parents were telling him to wear the mask. 10 other doctors told him to wear the mask. He didn't want to wear the mask. And so I took his side and said, "Yeah, it makes sense. Why would you want to wear the mask?" And I had met with the parents to prepare them for this first. And they were fortunately, they were patient. And it turned out, so after the 3rd visit, he decided he wanted to wear the mask, and then he made very quick progress. But again, if I had pushed, it's like it wouldn't have worked. And it's like you teach us, David, yes, do I want him to wear the mask? Of course I want him to wear the mask. But I can't be married to the outcome. I have to be totally neutral to the outcome. If he wears the mask, great. If he doesn't wear the mask, great. Whatever you want to do is fine. And that's, I think.
So that's the death of the therapist's ego, the codependent helping ego. You have to be willing not to help. And again, some therapists probably most therapists are just intensely opposed to that. They're determined they're going to help whether it helps or not.
The combination of TEAM and hypnosis, like with that little 5-year-old boy, did you end up doing any kind of hypnosis? You just really gave him TEAM therapy.
Yeah. Well, I mean, oftentimes when you do TEAM, you don't have to do hypnosis. I mean, I do things I use hypnotic language and therapeutic language, but yeah, with him, and then, imagine yourself doing this. And also he liked Legos. So what we did in the office, I bought a Lego set for him to do. And while he was doing the Lego set, he was able to wear his mask. So he took, for 20 minutes, he's building a Lego, and the mask was on for the longest it had ever been on. And so basically what you focus on, you amplify. So if I tell you, don't think of white horse, don't think of white horse, don't think of white horse, you're thinking of white horse right now. So if I focus on the mask versus focus on the Legos, he was able to do that. So
what you're saying is very obvious, and I'm pleased that you've picked it up and incorporated it so beautifully into your practice. I might say that the first person I ever heard about the use of TEAM integrated with hypnosis was from Matt May, who was, as you know, one of my first residents at Stanford. I don't know if he's one of the first, but one of the residents I worked with at Stanford, even when he was a medical student. And as you know, he's a great hypnotist and a great hypnotic subject. That's why I loved teaching him, because whenever I would teach him, he would go into a hypnotic trance. So anything I said, he thought was absolutely true. And then he would just go and do it exactly like I taught him. And it was kind of fun from that point of view. But he once said that, even when he's doing hypnosis, that it won't work unless the patient is motivated. That motivation is actually the key to hypnosis. And the first time he told me that, I have to admit that I didn't understand what he was talking about, even though it's now so totally obvious, because I used to do, as you know, hypnosis when I was a teenager, and I'd get my friends to do all these goofy things. And I was viewing it as this kind of involuntary, magical state. And but now it's so obvious that a paradoxical agenda setting is the key to hypnosis, as well as psychotherapy for depression, psychotherapy for anxiety, psychotherapy for marital problems, psychotherapy for treatment of habits and addictions, and as you've made us aware today, the treatment of this fifth categorization, somatic complaints, medical, chronic pain, and things of that nature. So thank you for that. And the reason I told my little story just now is because we might assume that parents or other therapists hearing this will readily grasp it. But it is so unintuitive that a lot of people simply can't see it at first. I, picked up on it pretty quickly because I was the one who was teaching Matt what he was just telling me. but still, when I heard it, it didn't compute for a few days. And I said, oh, that's what he's talking about. Of course, that is so cool. But I just wonder if you've been surprised by this, maybe fellow hypnotists and people who and you lecture all over the world and try to give out this message, but people who have trouble grasping what you're saying or comprehending it or believing it or.
Absolutely. When I lectured at the International Society of Hypnosis meeting a few years ago, and the title of my talk was More Important Than Hypnosis, using David Byrne's approach, Paradoxical Agenda Setting. And I was really honored. They gave me, the plenary room was a big audience, but people were shocked, and it was totally the opposite of what most people are used to. And I'd like to just say a couple more small things. One is to parents, because I'm hoping a lot of parents might listen to this, or even to therapists who work with parents. I'm thinking that two things. One is that, like if someone is playing tennis or basketball, whatever their sport is, and they don't play well, many parents afterwards will say, "Oh, you'll get them next time," or "Oh, gee, but you did so. You played well," or something that's disingenuous. They want to cheer the kid up. The kid doesn't want to be cheered up at that moment. You have to meet her. This kid feels disappointed. Hey, I didn't play well. And I imagine if you didn't play well, I imagine you feel frustrated. You want to talk about it. Imagine you feel frustrated, disappointed, sad, maybe a little embarrassed, so empathize. I think the best thing to do after something like that is not try to cheer them up, but meet them where they are, empathize, and then they can talk about, the next thing another time. But that's where I think a lot of, parents, they want to cheer their kids up and make them feel better. And that's not what the kid needs. And the other thing is parents,
Gosh, wait, can I just stop right there? That is so hard for parents to comprehend.
Oh, yeah. Yeah. Oh, horrible. Horrible. Yeah. It's out of love. They want to cheer their kid up. They don't want to see their kid suffering. Exactly, Rhonda.
Yeah. And so, I'm thinking of myself as a parent and watching my kids suffer, whatever they're going through. And it's very difficult to say, oh, you're still a great person. You're lovable. You're this. Oh, you're so talented. And to stop myself from saying that and just give them feeling empathy. It's very challenging.
Yeah. We'll have to have another program on the horrors of cheerleading.
Yeah, absolutely.
Because it's hard for people to stop. I remember I was giving a talk and I made a mistake. It was when one of my books came out. Must have been when Panic Attacks, and it was just a very humble type of thing. It was a bookstore on Castro Street in Mountain View, and there's probably 30, 40 people there. And I was just talking about, anxiety and panic attacks, and then some woman started complaining about her daughter won't do what I'm telling her to do. And, it was an interpersonal problem, conflict with the woman who's mad at her daughter and trying to control her daughter and get her daughter to do what she was telling her to do. And I made the mistake of, trying to help this woman in the audience, which was a huge mistake, the same mistake she was making with her daughter. And I said, well, that's not an anxiety problem, which is kind of what we're focusing on tonight, but more of a relationship issue. But I can tell you, it might be that you would benefit by learning some listening skills rather than trying to tell your daughter what to do. And then she barked at me. I listen just fine.
Okay.
What's wrong with my daughter? So I realized my mistake too late. But yes, it's really hard for anyone to hear. Even therapists, when they use my empathy scale, most of them find out that they're crappy even with their patients at empathy after they thought they were so great at empathy, and they take my empathy scale and get failing grades from most of their patients, most of their sessions. And it's hard for people to see just how badly we fail other people, especially when we think we're being so great. And recently, even we've been using kind of the 5 secrets in my app development team. You have some tools that maybe parents would want to look at on your website, or some videos and things like that. So would they go to your website to find some self-help kinds of things?
Absolutely. So for patients, the website is jefflazarusmd.com, JEF as in Frank, F as in Frank, LA, Z as in zebra, ARU, S as in Sam, MD like Michael David.com.
Is there a period after Lazarus, or just
Lazarus MD, all one word, .com. And it has there's several sections. There are actually video clips, which are, I think, I've been very fortunate. Some of my patients were very generous and allowed me to put video clips. There's a couple of my patients with Tics and Tourette syndrome, so there's a nice section on that for parents who have, and even for adults. I see children, adolescents, and adults. A nice section there. And there's also, if you look at I wrote what's called COVID Corner. It has, when COVID first came out, I wanted to create 2 short videos. One was using the magic dial to help patients with anxiety. Magic dial, as you know, a quick and powerful tool for anxiety. And it outlines, the paradoxical agenda setting. And the other is just a quick hypnosis session. Go to a special place in your mind where you feel happy, safe, and comfortable for relaxation. Those are nice tools that I wanted to make available to everybody. And there's sections on bedwetting and irritable bowel syndrome and such, performance anxiety. There's some video clips in the performance anxiety section. And the one last thing I want to leave a message for parents. The 2 things. One, parents often have, outcome, but more process resistance. They have to. The best advice I can give to parents when I see them in the office is, one, give your child, stay out of the process, let your child do this. And 2, give your child the unwritten, unspoken message, you can do this. It's not a cheerleader. It's like you said there, it's not, come on, son, come on, daughter, you can do this. And it's never a we can do this, because it's a we. It's not our problem. It's the child's problem. So the best advice is, stay out of the process and give them the unwritten, unspoken message. You can do this. We know you can do this. And that I think is the most helpful advice I can give to anyone.
Cool. Well, thank you so much.
Oh, thank you for this opportunity, David and Rhonda. It's really an honor and delight. And once again, David, I'm impressed by what a wonderful teacher you are, the way you purposely ask thoughtful questions and draw things out. It's just it's really wonderful to be part of this process. And once again, to watch you at work, David, it's a joy. And I look forward to your workshop in a couple of weeks. So thank you.
Great. Thank you so much.
Yes, thank you so much. And I forgot to say to the listeners that this is episode 315. I know it's the end of the podcast, but just want to put that in there.
Cool.
Jeff? Thank you so much. Bye.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.